Hello everyone, hope you're all doing good. In this video, we are going to discuss about Polycystic Ovarian Syndrome. So this is one of the commonest endocrinological disease that is affecting the women, and the prevalence nowadays is estimated around 10 to 15%. Okay. So this is called as a syndrome because the symptoms which the woman faces not only arises from her gynecological disturbances or her physiological disturbances, it also has its own metabolic components as well. Okay. Yes. So the symptoms the women face can include menstrual cycle disturbances, yes, that we all know, and there can be features of hyperandrogenism. Okay, hyperandrogenism features means, yes, there can be hirsutism, acne or alopecia, and it can also be associated with fertility problems. There can be obesity, and apart from these, there are so many psychological issues also the women faces, right? Psychological issues. Okay, right. Let's discuss about the pathophysiology of PCOS. So the pathophysiology of this condition is usually influenced by so many changes in ovarian folliculogenesis, neuroendocrine function, metabolism, steroidogenesis, insulin, both its production as well as sensitivity are affected, and it can even result in hyperinsulinemia. Apart from that, there can be inflammatory factors that can include a persistent low grade level of inflammation always present, and we all know there is also hyperandrogenism. Okay, so these are the group of pathophysiological changes that is going to happen in PCOS, right? Now let us see the pathophysiology in short. Okay, so what is going to happen is whenever there is environmental toxins or there is a genetic predisposition or gut dysbiosis is happening, and whenever there is a change in the diet or lifestyle, all these are going to present as hormonal imbalance, hyperandrogenism and insulin resistance. And with hormonal imbalance, there is a rise in LH-FSH ratio and there is a decreased level of follicle stimulating hormone secretion. Okay, with hyperandrogenism, there is more testosterone produced, but the sex hormone binding globulins are reduced, that will be resulting in free levels of testosterone that will be acting freely on the receptors. Okay, insulin resistance means there is increased levels of insulin resistance, that means there is glucose tolerance. Okay, so all these factors are going to contribute as polycystic ovarian syndrome, and that will be presenting to you with the features of polycystic ovarian system. Say clinical features like there will be hirsutism and acne, and the reproductive features like she will be having menstrual disturbances which can be due to oligo and ovulation, irregular menstrual cycle, and she may also present as a case of subfertility. And then metabolic features, there is increased risk of all the metabolic disorders as well. We'll be discussing it in short, right? Okay, so this is all about pathophysiology. I hope you'd have understood, right? Now, I just want to discuss about hyperandrogenemia alone here. Okay, so why this hyperandrogenemia is significant? Okay, so now we are going to discuss it one by one so that you will be getting a detailed concept about PCOS. Okay, so PCOS. First one, I am going to discuss about hyperandrogenism. Why we are discussing hyperandrogenism first? Because this is one of the biochemical hallmark of the whole set of syndromes, as well as this is one of the important factor which is going to present to you with clinical features. Okay, polycystic ovaries are not going to present as such, but when you see hirsutism, when you see acne, when you see baldness in a woman, yes, they are going to be suggestive of hyperandrogenism, which indirectly gives you a diagnosis of PCOS. Okay, so that's why this is important, right? Now, see, usually high levels of androgens are observed in 75 to 90% of the women with PCOS, and in these women mostly the other symptoms like oligomenorrhea will be present. Okay, so this excessive androgen synthesis can happen from the ovaries, but as well as the adrenals can also contribute to the production of these increased level of androgens. Okay, then what is happening is there is increased level of free unbound testosterone. Okay, free, that is unbound testosterone. So this is a major hormone that is contributing to the pathogenesis of PCOS, and this is also indicative of the excess androgenic activity in the female. At the early increased gonadotropin stage, okay, when you have increased gonadotropins early, these are going to lead to increased level of androgens. Okay, so this androgens will stimulate the growth of primordial follicles, as well as there is a rise in the antral follicles as well. Okay, so the release of gonadotropin hormones, okay, it is by the pituitary and it is under the control of gonadotropin releasing hormone, which is secreted by the hypothalamus. Okay, so what are the gonadotropins? Follicle stimulating hormone and luteinizing hormone. If you take luteinizing hormone, this will be activating the luteinizing receptor that is present on the theca cells. At the same time, follicle stimulating hormone is going to activate the FSH receptors that are present in the granulosa cells. Okay, and this will be converting the androgen to estrogens as well, and there is also stimulation of the follicular growth. Okay, so this is what is normally happening. Now, any dysregulation in this system, okay, so there is a dysregulation in the whole endocrine system, or there is an imbalance in the HPO axis, means that will lead to increased level of gonadotropin. Okay, suppose there is a problem with the ovary is not functioning properly now. What happens? The gonadotropins will try to stimulate it more, right? So, HPO axis, and here there is a dysregulation in the HPO axis. So, the gonadotropins are going to increase now. Okay? Yes. Also, there is an increase in gonadotropin releasing hormone as well, that will be resulting in a substantial hormone surge. So, that is why there is an increase in LH-FSH ratio as well. Okay. So, in this process what happens means the theca cells undergo hyperplasia because there is increased LH stimulation, and also there is buildup of follicular fluid that forms cyst along the ovarian periphery, and this will be giving an appearance like string of pearl. So, that is why we will be able to see a string of pearl appearance in PCOS. Clear? So, if you see an ovary like this and you have so many follicles like this, okay. So, what do you think? What are these cysts actually? So, these cysts are nothing but the follicles that are arrested in the preantral and antral stages, and this is mostly from the theca cells. Clear? Next one, due to rise in follicles and the expression of the essential enzymes as well that is involved in androgen synthesis, there are increased amount of androgens now. Clear? I hope the whole concept is clear. First we have discussed how the mechanism of HPO axis is going to act on the ovary, what are the hormones and in which cells they will be acting. So, this process, especially the LH, FSH action and it produce the converting the androgens to estrogens, this is especially called as two gonadotropin theory. Okay, two gonadotropin theory, because there are two cells, that is theca cells and radula cells in the ovary, which is being acted upon by the two gonadotropins. Okay, and if there is any dysregulation in this mechanism or there is any problem with the hypothalamus HPO axis, then gonadotropins are going to increase because the ovary is not going to function now. So, that will be increasing the gonadotropin releasing hormone as well, that will be substantially increasing the gonadotropin. So, only we have an increased LH-FSH ratio. That means LH is going to increase when compared to FSH, right? Then theca cells will be going for hyperplasia. At that time, what is going to happen is there will be follicular fluid cyst that will be seen across the periphery. These are nothing but the arrested follicles in their preantral and the antral stages. So, because the number of follicles are increasing, the enzymes acting are increasing and the androgen activity is increasing, which is leading to hyperandrogenism. Now, I hope you know two concepts. One, why there are polycystic ovaries in PCOS. Okay, why these polycystic ovaries are formed, and another one, why there is hyperandrogenism. Clear? Yes. Now, let's discuss about hyperinsulinemia. Okay, why hyperinsulinemia? The main hormone in lipogenesis as well as glucose homeostasis is insulin, right? So, insulin directly, it is going to mimic the action of LH and it indirectly raises GnRH as well. Okay? And you also have to know that increased level of insulin is going to be a cause of hyperandrogenism. Okay, that means there is excessive androgen production due to insulin increase also. Okay, sex hormone binding globulin, which is a key regulatory protein that is involved in regulating the testosterone levels, are usually decreased by the hormone insulin. Okay, so insulin is going to decrease the sex hormone binding globulin levels. So, what happens? The free testosterone is now going to increase. Okay. So, the lower sex hormone binding globulin levels will lead to increased level of androgens, and this is going to cause the clinical features of PCOS, say hirsutism, alopecia and acne. Let us discuss what is this gut microbiota dysbiosis. Okay, how this is important. See, there are three specific features of PCOS, say anovulation or menstrual irregularity, hyperandrogenism and the emergence of numerous small ovarian cysts. Okay, so all these are explained by a theory called dogma theory. of PCOS. That means dogma is nothing but, yes, it is the dysbiosis of gut microbiota. Okay. So, what is this theory? According to this theory, there is poor diet induced gut microbiota dysbiosis, microbiota dysbiosis that will increase the permeability of gut mucosa, that will again increase the passage of lipopolysaccharides. Okay, that means from gram negative bacteria that will be released into the bloodstream. Okay. So, when this is released, definitely we are going to get an immune activity, right? So, the resulting immune system activity disrupts the insulin receptor function, that will be elevating the insulin levels in the serum, then increasing the androgen levels in ovaries, and that is also interfering with the normal follicle formation. Clear? So, all these things are going to happen. Can you understand? Okay. So, basically, I will tell you the story behind this. Okay. So, what happened means, they conducted a study between the group of PCOS people and the group of normal people. Okay. And they found that these PCOS people were taking a food that is more in spices as well as metabolic products, that will be causing variation in diversity of the microorganisms that is present in the gut between these two groups. Okay. So, in the PCOS group, there were lowering of the beneficial bacterial growth like lactobacilli, whereas there is increase in pathogenic bacteria like E. coli or Shigella, like that. Clear? So, that is how the study was conducted, and this is the inference I told you. Okay. So, all the things are based on whatever the clinical features of PCOS, that is androgenism, then anovulation or emergence of small ovarian cysts is according to the dogma theory. Dogma theory is nothing but the dysbiosis of the gut microbiota. What happens means, there is a poor diet induced gut microbiota dysbiosis is happening when the diet is not good. So, that will be increasing the permeability of the gut mucosa. Then the dangerous bacteria which grow from them, especially from the negative group of bacteria, the lipopolysaccharides are going into the bloodstream, that is going to develop a immune system activity, and that is going to stimulate your insulin receptor function. Okay. So, that will be leading to increased insulin in serum. Already we have seen hyperinsulinemia is going to increase the androgens as well. So, there is hyperandrogenemia, as well as it is also going to interfere with the normal follicle formation as well, right? Yes. Next one. See, PCOS is definitely a polygenic and multifaceted disorder, and there are many genes that is going to act directly or indirectly, as well as the mutations in the genes are also important. Okay. So, these are some of the genes that are involved in the pathophysiology of PCOS. I am not going to detail into that, but you have to just know what are the genes. So the genes involved in the pathophysiology of PCOS means the genes which are controlling the ovarian and steroidal androgen steroidogenesis, adrenal steroidogenesis, say CYP21, CYP11A, CYP19 and 17, and insulin secretion and action controlling genes, namely IRS insulin receptor, okay, that is IRS1, IRS2, INS, INSR, like that. Then insulin secretion and action controlling genes like this is insulin receptor substrate 1, 2, then INS, INSR, like that, CAP, N10, okay. Effects of hormone, steroid hormone controlling hormones like androgen receptor hormone, sex hormone, binding globulin, then gonadotropin action and regulation, that is being regulated by LH, polystatin, FSHR, that is FSH receptor, then AMH, and others like FTO, PCOS1 and PAI1, okay. PCOS1 means Polycystic Ovarian Syndrome 1, and PAI means plasminogen activator inhibitor gene, and FTO means fat mass obesity gene. Clear? So these are some of the genes that is involved in the development of PCOS, either the genes directly or indirectly, or else the mutations as well, right? Now let us discuss the hormonal changes happening in PCOS. You have the hypothalamus, okay. First topmost center is the hypothalamus that will be acting on the GnRH to produce pulsatile GnRH. Then you have the pituitary that will be leading to increase in LH-FSH ratio. This gonadotropins are now going to act upon the ovary, that is nothing but the theca cells, and from the theca cells will be getting increase in androgens. Androgens are produced by the adrenals as well, not only by the ovarian theca cells, and the increased androgens will be usually taken to the adipose tissue to get converted into the estrogen by the enzyme aromatase. Androgens are converted into estrogen by the enzyme aromatase. Then this androgen will be going to act upon the skin, that will be because sex hormone binding globulin is reduced. So free testosterone is there. When it is acting on the androgen receptors, it will be causing hirsutism, acne, acanthosis, nigricans, like that. Then when there is a metabolism disorder in the adipose tissue, it will be leading to insulin resistance, and this insulin resistance is also going to cause the follicular atresia that will be resulting in anovulation and amenorrhea. And remember, this increased estrogen is continuously produced and there is no cyclical bleeding happening in some cases of PCOS. So that will be affecting the uterus as endometrial hyperplasia as well. So this is all about the hormonal changes. I hope you have understood, right? Yes. Let's discuss about the diagnostic criteria in PCOS. The criteria name is Rotterdam criteria. So here we have three factors, namely chronic anovulation, that is evident by oligomenorrhea, that will be usually less than or equal to 8 cycles in a year. Second one is, this can also present as polymenorrhea, okay. Remember, it is not only oligomenorrhea, sometimes polymenorrhea is also possible. Then there can be clinical or biochemical signs of hyperandrogenism, and finally you can even have polycystic ovarian disease that can be seen by ultrasonogram. And remember, it's not necessary that you should have all the three features. If you have 2 out of these 3 features, then also you will be diagnosing PCOS, right? Yes. And the next one is, recently we have another classification system that is given by PCOS Society, American Fertility Society, that is PCOS Society, AFS, okay. So the clinical and or the biochemical signs should be taken into account, that will include either ovarian dysfunction and or polycystic ovarian morphology. Clear? Yes. Now, let us discuss about the clinical features, right? So, what are the clinical presentations? So, clinical presentations will definitely include menstrual irregularities, as we have seen. So, there can be menstrual irregularities, and the second one include hyperandrogenism features. Hyperandrogenism features means acne, hirsutism, then oily skin, male pattern baldness, like that. Okay. Sometimes there can be adverse effects of the PCOS also. They can present with infertility or miscarriage, and there can be maternal complications that are seen in this women like GDM, FGR, preeclampsia, preterm labor, and sometimes even intrauterine death. Okay. And next one is about the metabolic syndrome. So, this is seen in about 30 to 45% of the females, and the syndrome usually includes many features, and it increases the risk of diabetes and cardiovascular disease. Okay. So, this is characterized by central obesity, impaired glucose tolerance, insulin resistance, hyperandrogenemia, type 2 DM, dyslipidemia, hypertension. Also, there can be subclinical atherosclerosis. Okay. Now, for this metabolic syndrome also, there is a diagnostic criteria which is very important. So, diagnostic criteria of metabolic syndrome includes female waist which is more than 35 inches. Second one is triglycerides which will be more than 150 milligram per deciliter. Third one is high density lipoproteins which are less than 50 milligram per deciliter. Then BP more than 130 by 85 millimeter mercury. And fifth point is fasting glucose which is between 110 to 126 milligram per deciliter, or the 2-hour glucose levels after giving a 75 gram of oral glucose will be between 140 to 199 milligram per deciliter. Clear? So, these are the diagnostic criteria: female waist more than 35 inches, triglycerides more than 150 milligram per deciliter, high density lipoprotein less than 50 milligram per deciliter, BP that is more than 130 by 85 millimeter mercury, and finally fasting blood glucose which is present between 110 to 126 milligram per deciliter, and 2-hour postprandial glucose levels that are present between 140 to 199 milligram per deciliter. Clear? Now, it is not necessary all the 5 features has to be present. Even if you get any 3 out of these 5 features, then you can diagnose metabolic syndrome in that woman. Clear? See, not always all the features of PCOS will be present in a single woman. Okay, sometimes even polycystic ovaries may not be found on the ultrasound, but even then you have to make a diagnosis of PCOS because of all the other associated features like hyperandrogenism or elevated androgen levels likewise. Okay, so there are so many phenotypes of PCOS. Okay, that's what I wanted to tell you. So, phenotypes of PCOS can fall under the category of hyperandrogenism plus oligo or anovulation. Second type is hyperandrogenism plus oligo or. So with this discussion of clinical features, I want you to make one thing clear, that not all cases of polycystic ovarian syndrome is going to present with polycystic ovaries as in the name of the disease. Okay. So some can be presenting with polycystic ovaries, some will be having additional hyperandrogenism, some will be presenting with hyperinsulinism or the metabolic fetus. So depending upon that, there are so many phenotypes of PCOS identified, and especially there are mainly four main phenotypes we are going to discuss. So the phenotype A, where they will have hyperandrogenism, ovulatory dysfunction and polycystic morphology, and the phenotype B, where they will have hyperandrogenism and ovulatory dysfunction, and the phenotype C, where there is hyperandrogenism and polycystic morphology, and phenotype D, where there is ovulatory dysfunction and polycystic morphology. Okay, and in all these phenotypes, the insulin resistance, glucose tolerance and diabetes risk is going to reduce as it is traveling from the phenotype A to phenotype D. Clear? Right. Now, so let me also tell one more syndrome that can be a clinical presentation, that is Hirsutism syndrome. Okay. Here you can have hyperandrogenism, insulin resistance, acanthosis, nigricans. Okay. So this is all about the clinical features. We are now going to discuss about the investigations in PCOS, right? So investigations, ultrasonogram when you do. So in ultrasonogram you will be able to see more than or equal to 12 follicles which are multiple, small, hypoechoic cyst in either ovary, either the right ovary or left ovary, that will be ranging between 2 to 9 millimeter in diameter. Or there can be an increased ovarian volume which will be more than or equal to 10 millimeter cube in either ovary. Okay. But these criteria you have to exclude that the woman is taking any oral contraceptive pills, right? Okay. Now let us discuss about the hormonal changes in women with PCOS. They have increased level of luteinizing hormone, normal follicle stimulating hormone, LH FSH ratio can be more than 2:1, and importantly about the androgen levels, that is testosterone levels. Normal levels of testosterone or less than 70 nanogram per deciliter, and in PCOS it can reach up to 200 nanogram per deciliter. Okay, whenever this is going more than 200 nanogram per deciliter, then you have to search for ovarian neoplasms. Okay, so that should be kept in mind. And another important investigation you have to give them is fasting insulin glucose, which will be increased more than 20 microinternational units per milliliter. Okay, and apart from that, we can even have an abnormal GTT, that is glucose tolerance test, also in this woman. So let me draw a table for it. Your HbA1c levels, your fasting glucose levels, and your 2-hour glucose tolerance test levels. Okay, so when it will be called normal, when it will be called impaired glucose tolerance, and when it will be considered as diabetes. Okay, so HbA1c levels, the normal range is up to 5.7%. When it is impaired glucose tolerance, it will be lying between 5.7 to 6.4%, and when it is diabetes, it will be arising more than or equal to 6.5%, right? And the next one is fasting glucose levels. Fasting glucose levels, normal range is up to 100 milligram per deciliter, and when it is lying between 100 to 125 milligram per deciliter, it is going to be impaired glucose tolerance, and when it is more than or equal to 126 milligram per deciliter, then it is going to be diabetes, right? And the next one is 2-hour GTT test. the normal range is always 140 milligram per deciliter, and when it is lying between 140 to 199, we will be naming it as impaired glucose tolerance. When it is arising more than or equal to 200 milligram per deciliter, then we will be calling it as a diabetes condition. Okay. And also the other hormonal changes you can have include decreased sex hormone binding globulin that we have already seen. There will be an abnormal lipid profile which will be coming under the diagnosis of metabolic syndrome. Then prolactin can be elevated in 10 to 20% of the cases, and anti-Mullerian hormone also increases by 2 to 3-fold. Clear? Okay. So these are the investigations we will be offering them. And finally, yeah, we can even offer them laparoscopy, where you will be able to see an enlarged ovary with white thick cortex and yeah, obviously multiple small cysts without any mature follicles. Clear? So this will be the laparoscopic finding, right? Now I want to discuss with you about the importance of obesity and PCOS. Will obese women only will get PCOS? No, that is not always true. Even thin women will also get PCOS. So let's see how that is possible. So PCOS and obesity. See, 65 to 74% of PCOS are obese, whereas 25 to 35% of PCOS patients are thin. Okay. Hyperinsulinemia is more in PCOS, and this is mainly due to insulin resistance rather than obesity. You have to understand that fact. Okay, it is hyperinsulinemia is not due to obesity, it is due to insulin resistance. But when there is obesity, this condition will be made worse. That also you have to understand, right? Now let us see insulin resistance in a thin woman will be about 30%, whereas in an obese woman this will be around 95%. Okay, and then see some obese women, if you take, they do not inherit the genetic predisposition to PCOS. So that's why they will have only mild insulin resistance, and that's why in them most of the times you will not see any hyperandrogenic features or even polycystic ovarian syndrome in ultrasonogram. Okay. But in some thin women, what happens means there is increased percentage of body fat, there is greater intra-abdominal, peritoneal and visceral fat, that is compared to a normal woman. Okay, that factor plays. And in so lean PCOS, there is also increased level of leptin levels and decreased levels of adiponectin levels. Okay, so all these changes are going to interfere with insulin signaling pathway, and that will result in insulin resistance in thin women. Clear? Yeah. So It is all about the increased percentage of body fat, which is going to bring about the PCOS changes under the insulin resistance features in lean women. Okay. Yeah. Now let us discuss about the management of PCOS. Okay. So management, we should know what are the aims of our management. Okay. Our aim of management, number one, we have to regularize the menstrual cycle. Number two, we have to reduce the excess androgen. Number three, we have to manage the clinical features, especially hirsutism, acne, etc. Okay. So these are the three factors we have to keep it in mind. Okay. Now let's discuss about the lifestyle management first. Okay. Lifestyle modification, diet modification and exercises. Okay. So these are the three important first line management you have to offer a woman with PCOS. So you have to give them a behavior modification also, like you should ask them to reduce their psychosocial stresses, and the diet should be reduced, and if it is increased, so if they reduce the intake of their calories up to 500 to 1000 kilocalorie per day, means they can reduce their body weight up to 7 to 10% in the next 6 to 12 months. Okay. You should at least ask them to do 30 minutes of structured exercise. Okay. So this is a minimal requirement. Minimum 30 minutes of structured exercise is necessary, and they can also be put on anti-obesity drug like Orlistat, which can be given at a dose of 60 to 120 milligram thrice daily. Clear? Sometimes you can even offer them bariatric surgery when the BMI is more than 40 kilogram per meter square without comorbidity, and when it is more than 35 kilogram per meter square with comorbidity. Okay. So in this case, when they have undergone a bariatric surgery, you have to advise them to undergo their fertility treatment or pregnancy, whatever, after 1 to 2 years, because there can be a risk of IUGR. Okay. And then what are the advantages of reducing weight and all these lifestyle management process? Okay. I already told you, even 5% weight loss can lead to regular cycles in a woman, that will restore ovulation as well as fertility in 75% of the women as well. Okay. Second one, this improves insulin sensitivity. Third one, this also improves sex hormone binding globulin levels. That means it decreases the free androgen levels. Clear? Yes. Next one is about the medical management in PCOS. So medical management in PCOS means have to know OCPs or the drug of choice in PCOS. Okay. So this is usually prescribed to adolescent or unmarried girls who are not ready to conceive. Okay. You can give combined oral contraceptive pills which have less androgenic properties or with reduced androgen effects like norgestimate or drospirenone, like that. Okay. Medroxprogesterone acetate given at a dose of 10 milligram for 12 to 14 days in a month. Okay. This is given for what? Yes, to bring about withdrawal bleeding. Why we have to bring withdrawal bleeding in these women? Already we have seen the excess estrogen is going to stimulate the endometrium and it is going to produce endometrial hyperplasia. So, that's why you have to keep the endometrial thickness at the cutoff level itself. Okay, so that's why you have to induce them with medroxyprogesterone acetate for withdrawal bleeding, right? And you can even offer them metformin if they have insulin resistance. Now, let's discuss about infertility in women with PCOS. So, infertility in women with PCOS, when PCOD is associated with infertility, you have to offer them metformin as well as ovulation induction. Okay. Now, let's see what are the drugs given and what are the doses at which you have to give these drugs. Okay. So, the first choice of induction is clomiphene citrate, that is given at a dose of 50 milligram per day, or you can even start with letrozole in some cases at a dose of 2.5 milligram for 5 days, usually between days 3 to day 7. Okay. So, clomiphene citrate is the drug of choice. And suppose if ovulation is not happening, then clomiphene dose, clomiphene citrate, CC is clomiphene citrate, the dose is increased. Okay. You can increase up to 150 milligram per day. And while doing this ovulation induction, anytime you see the ovarian follicle size between 18 to 20 millimeter, then you have to give injection HCG 5000 to 10,000 units. Okay. And then suppose if ovulation does not occur, you can even give clomiphene and you have to additionally give injection HMG, that is human menopausal gonadotropin, at a dose of 75 international units, that can be combined with HCG also. Okay. And after this, suppose all these medical treatment of ovulation induction have failed, then finally you will be offering them a laparoscopic ovarian drilling. Clear? Yes. So, this is how the ovulation induction is done in case of PCOS. First, you will be starting with clomiphene citrate at a lower dose, that is 50 milligram per day. Alternatively, you can even give them letrozole at a dose of 2.5 milligram for 5 days. It will be given between days 3 to day 7. And if ovulation is not taking place, then you have to increase the clomiphene citrate dose up to 150 milligram per day. And when the ovarian follicle size is reaching 18 to 20 millimeters, and then you have to give them the injection HCG at a dose of 5000 to 10,000 units. Suppose if again ovulation is not happening, then you have to give them clomiphene with injection HMG at a dose of 75 international units, that can even be combined with injection HCG. And if all this medical treatment are failing, then you have to give them laparoscopic ovarian drilling. Okay? Yes. And in some people, IVF is also a reasonable option when additional factors also coexist, either in the female, like there is tubal factors associated with PCOS. Okay, in that IVF can be reasonable. And suppose there is a male factor infertility, this directly you can go for a IVF. Okay. Now, let's see what are the surgical procedures you can offer for these women. Surgical procedures. Yes, just now we spoke about laparoscopic ovarian drilling. Okay. So, here we are going to puncture the ovarian capsule. Okay. Puncture ovarian capsule with an electrosurgical needle or laser beam. Okay. Usually we will be giving 5 to 10 punctures per ovary, and this will be usually given with a monopolar needle, and each puncture will be maintained for 5 seconds. It is not recommended as a first line of management because there can be chances of adhesion formation. Okay. So, whom do you offer this treatment? It is offered who don't respond to clomiphene citrate or any kind of ovulation induction, or there is increased risk of gonadotropin released sequelae. Okay. So, that is otherwise ovarian hyperstimulation syndrome. There is increased risk of OHSS. In this woman, we are going to give them directly surgical option. Clear? Yes. Now, let's discuss about PCOS in elderly. In women who are more than 45 years with menstrual irregularity, you have to confirm this by doing an endometrial biopsy also, and you have to manage the metabolic syndrome in this woman, which is very important. Okay, so additional investigations what you have to do, right? Next one is, let's discuss about the causes of oligo or anovulation. Okay, so what are the various causes of oligo or anovulation? Number 1, we have just discussed PCOS, that is seen in 80 to 90% of the people. Then it can arise due to hyperandrogenism or hypothyroidism, hyperprolactinemia, premature ovarian failure, primary ovarian failure also. Okay, so these are some causes of oligo or anovulation. Okay, so with this we will be completing the discussion on PCOS. I hope I have given a detailed concept of PCOS. I know this is a lengthy video, but you will be getting a conceptual based discussion of PCOS with this video. So until we meet in the next video, keep going, happy learning, take care and bye bye.